Okay, so picture this. It's like 2 a.m. You're the transplant surgeon on call, right? And your phone just goes off screaming, practically. An urgent alert. It's from UNO's DonorNet, the system for organ allocation in the U.S.
Yeah, it cuts right through everything, especially at 2 a.m.
Exactly. And there it is, a life-saving organ, maybe a liver, maybe a kidney. It's available. But here's the kicker. You've got maybe 60 minutes, tops, to make the call.
An hour, sometimes less, depending on where you are on the list.
An hour to wade through this flood of information. The donor's whole medical history, the latest labs, complex biopsy slides, maybe even like flight logistics.
Absolutely. You have to synthesize all of it. It's probably the most rapid, high-stakes calculation that happens in medicine today.
Wow.
Because it's not just, is this organ going to work technically? It's this whole ethical, logistical puzzle. You're balancing the risk of using a maybe marginal organ against the risk of your patient dying while they wait for the next offer, which might not come.
Right. That intense pressure, that decision point, that's our vision today. We're doing a deep dive into exactly that. We want to understand the criteria, the tools they use, and, well, the massive ethical weight on surgeons evaluating these deceased donor offers for kidneys and livers. We're sort of working from a blueprint, like a guide surgeons themselves might use, to see how they turn all this raw data, medical reports, policy rules into that life or death choice.
All about trade-offs. Profound ones.
Okay, let's dive in. Let's unpack this. Starting with how they first signs up the organ itself, the donor quality assessment.
Right. So it starts the second that offer comes in with the info provided by the the organ procurement organization. Surgeons, they immediately start triaging, thinking in terms of risk profile. We often talk about the big three donor categories.
Okay, the big three. Let's start with what seems most obvious. The donor's age and their medical history. That has to be a big flag, right?
It is often the first thing you notice, yeah.
Yeah.
But it's nuanced. So advanced donor age, maybe over 60 for kidney, over 70 for a liver, that immediately tells you something about expected longevity. The organ might not last as long.
Okay.
But honestly, age alone isn't the whole story. Sometimes it's less important than the history. Was there long-standing hypertension? But like uncontrolled hypertension?
Oh.
Decades of diabetes? These things cause this slow, cumulative damage to the small blood vessels. Microvascular damage. You might not see it on the surface labs immediately.
And I guess the cause of death itself could be a huge clue about that hidden damage.
Oh, absolutely. It's a massive signal. Let's say the donor died from a stroke, a CVA.
Right.
That often suggests there were already widespread vasculopathies, problems with the blood vessels throughout the body, hardening damage.
So the arteries and tiny vessels feeding that kidney or liver were likely compromised before the stroke even happened?
Exactly. So if I see, say, a 68-year-old donor died of a hemorrhagic stroke, I'm already thinking the vessels in that offered kidney probably have some wear and tear, regardless of what the creatinine level is right now.
Got it. So even if the labs look okay at first glance, the surgeon has to kind of weigh that history, that underlying structural risk, more heavily sometimes.
You have to. It's part of the picture.
Yeah.
The second big area is the donor's hemodynamic stability. Basically, what was their final course like in the ICU?
Okay, how stable were they?
Yeah. The surgeon's asking, did this organ take a major hit from lack of blood flow before it's procured? We look for signs like, did they have long periods of really low blood pressure, severe hypotension?
Right.
Or did they need massive doses of vasopressors? Those are drugs to keep the blood pressure up, just to maintain a basic level.
Which would mean the organs weren't getting enough oxygenated blood.
Correct. Starved of oxygen. And this becomes absolutely critical when you talk about DCD donors, donation after circulatory death.
Ah, right. That's different from brain death donation.
Completely different pathway, and the evaluation is different. With DCD, the donor isn't brain dead. Life support is withdrawn, and procurement happens after the heart stops beating.
Okay.
So for DCD organs, we become obsessed with something called warm ischemia time. WIT.
Warm ischemia time. What is that exactly?
It's the time window after blood circulation stops for good, but before the OPO team can get the organ flushed with cold preservation solution and cooled down.
And we're talking minutes here, right? Not hours.
Yeah, minutes. Usually under 30 minutes is the goal, often much less for livers. Because without any blood flow, the organ tissue starts dying from lack of oxygen almost immediately. That warm time is incredibly damaging.
How damaging?
Well, for a liver, a warm time over, say, 30 minutes, some centers draw the line even lower, like 20. It dramatically increases the risk of serious complications. Things like ischemic cholangiopathy, which damages the bile ducts, or even primary non-function.
Primary non-function, meaning the liver just never wakes up.
Exactly. It never starts working after transplant. Catastrophic outcome. Now, DCD kidneys are used much more often. They can handle it a bit better.
Yep.
But even they come with a known higher risk of what we call delayed graft function, or DGF.
Meaning the kidney doesn't work right away?
Correct. The recipient might need dialysis for days, maybe weeks, while the kidney recovers from that initial ischemic hit. It's a known risk, a trade-off we accept to be able to use more organs and save more lives.
Makes sense. Okay, so that was hemodynamic stability and DCD. What's the third part of the big three, specific to kidneys?
Right. For kidneys specifically, we look hard at the renal function markers.
Yeah.
Any signs of kidney injury, either chronic or acute, right before donation.
Like the creatinine level.
Exactly. Check the trend of the serum creatinine.
Mm-hmm.
Was it rising? Did the donor have an episode of acute kidney injury, AKI? Did they need emergency dialysis? Or maybe their urine output just plummeted, what we call anuria, less than 100 milliliters in a whole day.
Those sound like major red flags.
They are. They're stress signals for the kidney. But, and this is really important, a history of AKI doesn't automatically mean the kidney's unusable.
Oh, interesting. Why not?
Well, we often find that if the creatinine level was starting to come down before procurement, or if the urine output picked back up, it suggests the injury was temporary, reversible.
Ah, okay.
So in those cases, the surgeon knows they might be facing that delayed graft function we talked about.
Right, the need for temporary dialysis post-transplant.
Exactly. But they also know the kidney has a good chance of recovering fully. It's a calculated risk again.
This whole triage process, these big three factors for kidneys, it leads us to this single number that seems to dominate kidney allocation, the KDPI, Kidney Donor Profile Index. How does one number capture all that risk?
Well, the KDPI is.
Yeah.
It's a really clever, though sometimes controversial tool. It's a percentile score, 0 to 100%. And it's generated by an algorithm that looks at 10 different donor factors. Things like age, weight, height, ethnicity, whether they had hypertension or diabetes, the cause of death, and that final creatinine level.
So it bundles all that together.
Right. It essentially compares the expected functional lifespan of this specific kidney against all the kidneys transplanted in the U.S. the year before. It gives you a relative ranking.
So a low KDPI, say 15%, means this kidney is expected to function longer than 85% of other transplanted kidneys. That sounds like a great organ.
That's exactly right. A KDPI under 20% is generally considered a very high-quality, low-risk, standard criteria organ, expected to last a long time.
So where does the risk really start to climb? Where's the threshold?
The guidelines and sort of common practice highlight KDPIs greater than 85%. If an organ has a KDPI of 85% or higher, it means it's predicted to function worse than 85% of all kidneys transplanted. These are often called marginal, or historically expanded criteria, donor kidneys. And policy actually mandates special scrutiny and informed consent for these high KDPI organs. Usually triggers the need for a biopsy too.
Okay, but isn't there a tension here? If KDPI is heavily weighted by age and centers only want low KDPIs, doesn't that effectively sideline organs from older donors, even if they might be perfectly good for some recipients?
That is the central conflict. Absolutely. There's huge pressure from national policy, from UNOS, to increase the utilization of these higher KDPI kidneys, to not waste them.
Because people are dying on the wait list.
Precisely. So centers are pushed, sometimes required by oversight metrics we can talk about later, to accept kidneys with higher KDPIs.
Which means consciously accepting an organ that might only last, 5-8 years instead of maybe 15 or 20?
Yes. You're trading expected longevity for immediate utility. Getting someone off dialysis now. For the surgeon and the patient, accepting that, say, 90% KDPI kidney means prioritizing the chance at life off dialysis right now, even if it's for a shorter time, over waiting longer for potentially a better organ that might never come.
It's a heavy decision. Now, what's really interesting is you mentioned the liver transplant world hasn't gone for a single score like KDPI. They stick to a more holistic approach.
Yeah, the liver community has largely resisted a single index. The thinking is the liver is just too complex, its regenerative capacity is unique. Reducing it to one number felt like oversimplification.
So how do they assess liver risk then?
It's more of a subjective synthesis, looking at a constellation of factors. But the single biggest structural concern, the thing everyone focuses on first, is hepatic steatosis, fatty liver.
Right, the amount of fat in the liver. And that's measured how? Biopsy.
Yes. The OPO coordinator typically gets a biopsy at the time of procurement. The pathologist reads it and quantifies the amount of macrovesicular fat, the big fat droplets inside the liver cells.
And are there clear thresholds, like how much fat is too much?
There are generally accepted ranges. Mild steatosis, let's say less than 30% fat, is usually considered acceptable. Manageable risk.
Okay.
When you get in moderate fat, maybe 30% to 60%, the risk starts to climb significantly. That fat makes the liver much more sensitive to injury during preservation and reperfusion, doesn't handle the stress well.
And severe fat.
Severe, usually defined as over 60% fat. That's almost always a reason to decline the organ. The risk of primary non-function, the liver just failing immediately, is considered unacceptably high by most centers.
Wow. So if you get an offer for a liver from a DCD donor, which already has that warm ischemia risk, and then the biopsy comes back showing moderate, say 45% fat, that combination sounds really dangerous.
That's exactly the kind of double-hit scenario surgeons dread. You have the ischemic injury from the DCD process, plus an organ intrinsically weakened by fat. It's a very high-risk proposition.
Are there other major flags for liver quality besides fat?
Yes, definitely. We look closely at the liver enzyme levels, particularly the transaminases AST and ALT. If those are sky high, say over 5,000 IUL,
Also, it indicates.
massive recent liver cell death. It suggests the liver suffered a severe injury shortly before or during the donation process, maybe profound shock or ischemia. An injury that severe means it's unlikely to recover function after transplant. Some centers even have automatic filters in DonorNet to bypass offers if the enzymes are that high.
So pulling that together, that 2 a.m. decision looks really different depending on the organ. For a kidney, you're maybe focusing on that KDPI number first. For a liver, you're looking right at the biopsy for fat percentage and checking those enzyme levels.
It's a fundamentally different initial risk assessment. Which leads us nicely into the next layer, digging deeper into the pathology and the immunology. Because often, especially for these borderline marginal organs, the final decision comes down to what you see under the microscope or in the immune tests.
Right. Section 2. The immunologic and pathologic deep dive. Why are biopsies so crucial, especially for those higher risk kidneys, the high KDPI ones, or from older donors or donors with diabetes?
For those kidneys, the biopsy takes you beyond the statistical prediction of the KDPI score to the pathological reality of the organ. Is there actual, irreversible, chronic damage?
And what are you looking for specifically?
Two main things that indicate long-term wear and tear. First is the percentage of glomerulosclerosis. That's scarring in the glomeruli, the tiny filtering units of the kidney.
Okay, scarring.
Second is the degree of vascular sclerosis, particularly arterial intimal fibrosis. That's hardening and thickening of the walls of the small arteries within the kidney. Both of those things are chronic, non-reversible damage.
And is there a threshold for that scarring percentage where surgeons typically draw the line?
It varies a bit by center, but generally if the glomerulosclerosis is more than, say, 20% to 30%, alarm bells start ringing. If it's high, and there's also significant vascular disease seen on the biopsy, many surgeons would decline that kidney for a standard single transplant.
But you mentioned earlier sometimes they might still use it.
Right. This is where the strategy of dual kidney transplant comes in. If the biopsy shows moderate chronic changes, but maybe not severe, and the kidneys are from an older donor or have a high KDPI, the surgeon might consider taking both kidneys from that donor and putting them into one recipient. The idea is to pool the remaining function to provide enough total filtering power.
Interesting strategy. But the sources also mentioned some caution about relying too heavily on these quick OPO biopsies. There's a risk of discarding good organs.
Yes, this is a really significant issue and a source of debate. The biopsy performed by the OPO is often done quickly. It's usually a frozen section, not the higher quality permanent section.
What's the difference?
Frozen sections can introduce some artifacts, slight distortions in the tissue structure. And it's often read by a general pathologist on call at the donor hospital, maybe not a specialist renal pathologist who reads these all day long.
So the interpretation can be subjective.
Very subjective.
Yeah.
And under time pressure. So a pathologist might be cautious, maybe slightly overcall the percentage of sclerosis. The surgeon gets that report
And declines the organ.
and declines it. Even though maybe if it had been read by an expert or on a permanent section, it might have been deemed acceptable. Once it's declined based on that biopsy, it gets offered down the list, potentially declined again, and might end up being discarded.
A potentially usable organ gets wasted because of interpretation variability?
Exactly. Improving the standardization and quality of these pre-transplant biopsies is a huge focus for policymakers right now. We need to reduce that unnecessary discard rate.
Makes sense. Now, for the liver biopsy, you said its main role is checking that fat content, maybe looking for fibrosis if it's suspected. What about anatomy?
Yeah, the liver biopsy confirms the steatosis severity, primarily. But the OPO team also does an anatomical inspection during procurement for both kidney and liver donors.
Right.
They're looking for anatomical variations. For example, does a kidney donor have multiple renal arteries instead of the usual one?
Okay.
Or, for the liver, is there a replaced hepatic artery, meaning it branches off an unusual vessel? These things don't necessarily stop the transplant.
But they complicate it.
They definitely make the recipient surgery longer and much more technically demanding. It increases the surgical risk. So the surgeon needs to know about that anatomy beforehand to plan accordingly and maybe factor it into the overall risk assessment.
Got it. Okay, let's shift gears from the physical organ to the invisible threats. Infectious diseases. There's been a huge change regarding hepatitis C, hasn't there?
Oh, it's been revolutionary. Truly one of the biggest positive shifts in donation in the last decade or so.
What changed?
So previously, if a donor tested positive for hepatitis C virus, or HCV, that organ could generally only go to a recipient who already had HCV.
Right, matching infection status.
Exactly. But now we have these incredible drugs called direct-acting antivirals, or DAAs. They're pills taken for maybe 8, 12 weeks, and they cure HCV infection in almost 100% of cases.
Wow, cure it.
Cure it. So this breakthrough means we can now confidently take an HCV-positive organ, usually confirmed by a nucleic acid test, or NAT positive, and transplant it into an HCV-negative recipient.
And then just treat the recipient with the DAAs afterwards.
Precisely. You treat them after the transplant, and the infection is cleared. It's been a game changer for expanding the donor pool, especially for kidneys.
That must open up so many possibilities for patients who've been waiting a long time, maybe because they're hard to match immunologically.
It does. For someone high on the list or someone highly sensitized, the small risk and inconvenience of taking DAAs for a few weeks pale in comparison to staying on dialysis for years or dying waiting for a liver.
Is there a catch?
The only, not catch, but absolute requirement is transparency and rigorous informed consent. The recipient has to fully understand they're receiving an organ with HCV, understand the treatment plan, the success rates, any potential, though minimal risks, and explicitly agree to it in writing.
Makes sense. Beyond HCV, there's this category called PHS increased risk donors. Public health service. What does that mean?
Right. This category isn't necessarily about a positive test result, though sometimes that's involved too. It's based on the donor's recent behavioral history, things that might increase their risk of having acquired certain infections like HIV or hepatitis B or C, even if their tests right before donation were negative.
Because of the window period for testing?
Exactly. There's a short window period after exposure where someone could be infectious but not test positive yet. So the PHS criteria flag donors with specific risk factors, things like recent IV drug use, certain sexual behaviors, incarceration history within a defined time frame, usually the last 12 months.
So it's about potential exposure risk, not confirmed infection.
Correct. The actual risk of transmission from most PHS increased risk donors, given modern sensitive testing, is incredibly tiny, almost vanishingly small.
But you still have to tell the recipient.
Absolutely. It's a regulatory requirement and an ethical one. The recipient must be informed that the donor met these PHS criteria, understand what that means, understand the very low residual risk, and provide specific written consent to accept that organ. It's about autonomy.
Got it. Okay, so we've looked at the organ quality, the pathology, the infection risk. Now I get to the patient side of the equation. Section 3, recipient compatibility. And this seems to be where urgency and immunity really drive things differently for liver versus kidney.
Yeah, this is where the paths really diverge. Let's start with urgency. For the liver, urgency is basically defined by how close the patient is to dying without a transplant.
Measured by the MELD.
Primarily, yes.
Yeah.
The MELD score model for end-stage liver disease predicts 3-month mortality on the wait list. A higher score means higher risk. Or the status 1A, which is for patients with acute liver failure who could die within days.
And that level of urgency must completely change the surgeon's thinking about accepting a less than perfect organ.
It overrides almost everything else. The question shifts dramatically. It's no longer, is this the best possible liver? It becomes, if I turn this liver down, will my patient be alive to get the next offer?
Right.
So a patient with a MELD score in the high 30s or 40s, or someone listed status 1A, they and their surgeon are almost certainly going to accept a much higher risk liver. Maybe one with moderate fat, maybe from a DCD donor, maybe with extended cold time, because That marginal liver is their only shot at survival right now.
Okay, contrast that with the kidney patient. They have dialysis.
Exactly. Dialysis is the safety net. It keeps people alive, often for years. So the urgency for kidney transplant is relative. It's about improving quality of life, getting off dialysis, long-term health, but generally not about immediate life or death survival in the next few days.
So the decision calculus is different.
Completely. If a surgeon gets offered that high-risk kidney, say the 90% KDPI one we talked about for a patient who is stable, doing reasonably well on dialysis, the ethical balance often tips towards waiting for a potentially better, lower KDPI kidney that promises more years of function. They can afford to prioritize longevity over immediacy because dialysis provides that bridge.
So the core ethical question, waitlist risk versus transplant risk, it really hinges on whether dialysis is available.
That's a perfect way to put it. The liver surgeon often has to gamble on the transplant itself to ensure immediate survival. The kidney surgeon usually has the luxury, ethically speaking, to be more selective to maximize the long-term outcome.
Okay, let's talk about the other big divider, the immune system. For kidneys, you said the immunology is everything. HLA, matching, cross-matching.
Yeah, for kidneys, the immune compatibility is paramount. We look at the HLA match, human leukocyte antigens. These are proteins on cells that the immune system recognizes. A better match generally means less risk of rejection long-term.
And then there's the CPRA, calculated panel reactive antibody.
Right. CPRA measures how sensitized the patient is. Basically, what percentage of the general donor population does this patient already have antibodies against, usually from previous transplants, pregnancies, or blood transfusions?
And if someone has a CPRA of like 99 or 100%?
That means they're highly sensitized. They have preformed antibodies that would react against almost any potential donor. Finding a compatible kidney for them is incredibly difficult.
So they get special priority.
Yes. Allocation policy gives highly sensitized patients extra points, recognizing how rare a compatible match is for them. But the absolute final, non-negotiable immune test before any kidney transplant is the crossmatch.
Okay, explain the crossmatch. What is it actually testing?
The final crossmatch directly tests the recipient's blood serum against cells from the specific donor whose kidney is being offered. We're looking to see if the recipient has preformed antibodies that specifically target that donor's HLA antigens.
And if it comes back positive?
A positive crossmatch is a hard stop. It means the recipient's immune system is primed and ready to violently attack that specific kidney the moment it's transplanted. It would cause hyperacute rejection.
Hyperacute rejection? What does that actually look like? It sounds bad.
It's devastating. It happens within minutes to hours of reperfusing the kidney with the recipient's blood. The antibodies attack the blood vessel lining inside the kidney, causing immediate clotting, swelling. The organ literally turns black and dies right there on the operating table.
Wow, okay. So a positive cross-match means immediate refusal. No way around it.
Absolutely. The transplant cannot proceed. You have to decline the organ. Guaranteed graft loss otherwise.
Now, compare that immune complexity to the liver. You hear the liver is immunologically privileged. What does that mean?
It means the liver is just much less likely to provoke a strong immune reaction compared to the kidney. For routine liver transplants, we generally do not need to worry about HLA matching.
Really? No HLA matching?
Nope. A liver transplant can be highly successful even with 0 HLA matches between donor and recipient. It removes this huge layer of immune complexity from the decision.
So what is the main immune barrier for livers then?
Primarily just ABO blood type compatibility. You need a compatible blood type, same as for any transfusion or other organ. Beyond that, the main compatibility check for liver is physical size.
Ah, right. Size matching. Why is that so critical for the liver?
Because if the donor liver is too small for the recipient, it can lead to something called small for size syndrome. We generally aim for the donor liver's weight to be at least 0.8% of the recipient's body weight. That's the GRWR, graft to recipient weight ratio.
And if it's below that, what happens in small for size syndrome?
The undersized liver graft just gets overwhelmed. It can't handle the metabolic demands of a larger recipient's body. It leads to really poor function, jaundice, problems with blood clotting, fluid accumulation, often requires urgent retransplantation or the patient dies.
So another critical check, ABO type, then liver size.
Absolutely. Got to confirm both early on.
Okay, one last check before the surgeon finally says yes to the organ offer. The patient's immediate readiness, right?
Yeah, this is the final gate check. Can the patient actually undergo major surgery right now? Do they have some new medical issue like an active infection or maybe a sudden heart problem that make surgery too risky at this moment?
Things that might have popped up since their last clinic visit.
Exactly. And then the logistics. Can they physically get to the hospital quickly? We're often talking arrival within just a few hours. And if they're a kidney patient, do they need a dialysis run right before surgery to optimize their fluid status and electrolytes?
Because once that organ is accepted, the clock is ticking really fast.
The clock is ticking. Accepting the offer sets a whole complex chain of events in motion transport or booking team assembly. The patient has to be ready to go medically and logistically right then.
Okay, we've got the organ assessed, the recipient checked out. Now comes the race against time and distance. Section 4, the logistics and technology gauntlet. The big enemy here is cold ischemia time, CIT.
Right. CIT, that's the time the organ spends out of the body, on ice or a pump, between being removed from the donor and having blood flow restored in the recipient. And every minute counts because the organ is slowly sustaining damage during that time.
And you mentioned earlier the liver is especially sensitive to this.
Extremely sensitive. Ideally, you want the CIT for a liver to be under, say, 12 hours. Many centers aim for 8 hours or less if possible.
12 hours max. That's not a lot of time, especially if the donor's far away.
It's not. And that's why logistics are so critical for liver offers. The sources mention high-volume centers might even have automated filters in DonorNet.
To do what?
To automatically bypass liver offers coming from beyond a certain distance, maybe 1,500 nautical miles or something. Not because the organ is bad, but because the risk of unavoidable transport delays making the CIT too long is just too high.
So liver transplants often happen overnight.
Very often. Teams work through the night to minimize that cold time, get the organ procured, flown, and transplanted as fast as humanly possible.
But kidneys are more forgiving.
Much more forgiving, thankfully. A kidney can generally tolerate 24 hours of cold time, sometimes even a bit longer, especially if it's put on a machine perfusion pump instead of just static ice storage.
And that extra time gives the team flexibility.
Huge flexibility. If a really good kidney offer comes in at, say, 3 a.m., the surgeon might decide, okay, let's accept it, get it here, put it on the pump, and schedule the surgery for 7 or 8 a.m. Allows the whole team, surgeon, anesthesiologist, nurses, techs, to get some rest and start fresh. That likely improves safety and reduces the chance of errors during a long operation.
That makes a lot of sense. Now, all this information sharing, the offers, the timing, it's all managed through the central system, DonorNet.
Yes, DonorNet is the nerve center. It's the secure web-based system where OPOs list the organs, transplant centers receive the offers via alerts, usually to their phones.
Right, that 2 a.m. alert.
Exactly. All the donor information, lab results, biopsy reports, images, they're all uploaded as attachments in DonorNet. And the system tracks the response times. Centers usually have only 60 minutes to respond to an initial kidney offer before it automatically goes to the next center on the match list.
60 minutes? That's intense.
It forces quick decision-making. You can't sit on an offer.
So, to handle that constant flow of offers, especially at busy centers, they use these automated offer filters.
Yeah, offer filters are essential for efficiency. Programs can set up customized rules within DonorNet to automatically screen out offers they know they would almost never accept based on their established criteria.
Like what? Give me an example.
Okay, a center might say, filter out any kidney offers from donors over age 75 if the KDPI is also over 95%, unless the donor hospital is within 100 miles. You can combine criteria.
So it stops the surgeons from getting alerts for organs they're highly unlikely to use anyway, reduces the noise.
Exactly. Reduces alert fatigue. And here's a key point. If an offer is bypassed by these preset automated filters, it does not count as an official decline against the center's performance metrics.
Ah, that's important for their oversight.
Very important. It lets them focus their time and cognitive energy on the offers that are actually potentially suitable for their patients.
And looking even further ahead, AI tools are starting to play a role here too.
Yeah, it's an emerging area. There are tools being developed, like the Organ Offer Explorer mentioned in the sources, that use machine learning.
How does that work?
It analyzes a specific center's own historical acceptance and decline patterns. So the AI learns, okay, this center has declined 95% of kidneys with KDPI over 90%, combined with cold time over 18 hours. So when a similar offer comes in, the AI can flag it as low probability of acceptance for this center, or potentially even autofilter it based on the center's learned preferences. The goal is to act like a smart assistant, helping the surgeon zero in on the most promising offers faster.
Fascinating. And technology isn't just helping sort the offers, it's also helping assess the organs themselves, even keep them viable longer with machine perfusion.
Yes. Machine perfusion is a huge technological advance, especially for marginal organs. For kidneys, the most common type is hypothermic machine perfusion, HMP, basically pumping cold preservation fluid through the kidney instead of just letting it sit on ice.
And what does that tell the surgeon?
While it's on the pump, the OPO or perfusion technician can measure things like the flow rate through the kidney's vessels and the vascular resistance. If a high KDPI kidney shows really good flow characteristics on the pump.
It gives the surgeon more confidence.
Exactly. It provides objective data suggesting the microvasculature is actually in decent shape despite the risk factors. It can be very reassuring and tip the balance towards accepting an organ they might have declined based on stats alone.
Okay, and for livers, there's something even more advanced, normothermic perfusion.
Right. NMP normothermic machine perfusion is really exciting for livers. Normothermic means warm, body temperature.
So you're keeping the liver warm outside the body.
Yes, using devices like the organ care system mentioned. You're perfusing the liver with warm, oxygenated blood, nutrients, essentially keeping it alive and functioning outside the body.
That sounds like science fiction.
It feels like it sometimes.
Yeah.
But it's not just preserving the liver, it allows for functional assessment before transplant. You can measure, is it making bile? Is it clearing lactate, which is a marker of metabolic function?
So you can actually see if it works before putting it in the patient.
Precisely. It dramatically reduces the uncertainty around those really marginal livers, especially DCD livers or ones with moderate fat. If it performs well on the NMP device for a few hours, the surgeon gains huge confidence to proceed. It can turn a likely decline into a safe acceptance. It's the ultimate test drive.
Incredible. Okay, we've navigated the medicine, the logistics, the tech, but hovering over all of this is policy, ethics, accountability, Section 5.
Yeah, the surgeon isn't operating in a vacuum. They're bound by strict rules and profound ethical responsibilities.
The first being stewardship.
Ethical stewardship of a scarce, life-saving resource. That's paramount. Surgeons have to follow the national allocation policies laid out by OPTN, the Organ Procurement and Transplantation Network, managed by UNOS.
And those policies are designed for?
Two main goals: maximizing patient benefit, saving the most lives, getting the most years of function out of each organ, but doing it with absolute fairness according to the established rules, like MELD score for livers, waiting time, and points for kidneys. No cherry picking allowed.
But you also mentioned centers have their own internal protocols, like specific KDPI cutoffs they won't go above.
Yes, centers develop their own internal guidelines based on their experience, their patient population, their risk tolerance. It ensures consistency within their program.
But what if a center is too conservative? If their internal cutoff is much lower than average, aren't they potentially wasting organs?
That's exactly the concern national oversight tries to address. If a center consistently declines organs that most other centers would accept, it contributes to organ wastage and waitlist deaths.
And this is where that OAR ratio comes in, the offer acceptance rate ratio.
Exactly. The OAR ratio, which UNOS implemented fairly recently, specifically monitors this. It compares a center's actual acceptance rate for offers of a certain quality level to the expected acceptance rate based on national data for similar offers.
So if a center's acceptance rate is way lower than expected,
it flags them for review. The message is, you seem to be declining transplantable organs more often than your peers. Why? It puts pressure on centers to essentially accept more marginal organs to push their utilization rates up.
That creates a real ethical tension for the surgeon, doesn't it? The pressure to utilize versus the desire to guarantee the best possible outcome for their patient.
It's a huge tension. The policy pushes for maximizing organ use to reduce waitlist deaths, which is a vital goal. But the consequence is potentially pushing surgeons to accept organs that carry a higher risk of complications or early failure, which could impact their center's reported outcomes.
So they're caught between system goals and individual patient outcomes.
They really are. It's a constant balancing act. And that's why documentation becomes so important.
Right. Documenting the reason for refusal if they do decline an organ.
Absolutely. When declining an offer in DonorNet, the surgeon has to select a specific refusal code like donor age equality, biopsy findings, logistics, positive crossmatch.
And document it in the patient's chart, too.
Yes. It provides transparency and accountability. It shows the decision was based on a careful medical assessment of the risks and benefits for that specific patient in that moment, not just arbitrary preference. Especially crucial when declining a marginal organ that another center might have taken.
Let's touch on one more policy nuance. Multi-organ transplants, like liver, kidney. How does that work allocation-wise?
Right, this policy often raises questions. It's based on the principle of maximizing overall utility. If a patient needs a liver transplant urgently, and they also have significant kidney failure requiring a kidney transplant, the allocation system generally prioritizes them to receive both organs from the same donor if a suitable multi-organ donor becomes available.
Even if there's someone else who's been waiting longer just for a kidney.
Yes. The liver need drives the allocation priority in that scenario. The rationale is that the liver failure patient is facing imminent death without the liver, and they often need the simultaneous kidney transplant to survive the perioperative period and have a successful recovery.
So it's deemed the way to save the most life years overall from that one donor.
That's the justification. It's prioritizing the patient with the most acute, life-threatening need, even if it means bypassing someone with longer waiting time for just one of the organs.
Okay. This whole intricate web of medicine, logistics, ethics, it really highlights the different worlds of kidney and liver transplant. Which brings us to our final synthesis. Section 6, kidney versus liver. A difference in mindset.
Yeah, the day-to-day reality, the pressures, the core decision drivers, they feel fundamentally different between the two specialties.
Let's quickly recap those key differences. First, the whole sense of time and urgency.
Liver transplant feels emergent, almost always. That tight CIT window, the patient often being critically ill. It forces rapid decisions, often overnight, and demands a higher tolerance for accepting imperfect marginal organs just to get the transplant done now.
Whereas kidney transplant is more elective in its timing.
Elective in timing, yes, though certainly not a necessity. But dialysis allows for planning. Decisions can be more deliberate. You can wait for better quality, prioritize the long-term outcome over immediate transplantation if the risk seems too high.
Then there's the matching complexity, pulls apart.
Totally. Kidney transplant is dominated by immunology, HLA matching, CPRA screening, that critical final crossmatch. A positive crossmatch stops everything. Immune compatibility is king.
And for liver.
Immunology is mostly a non-issue. It comes down to basic ABO blood type and getting the size right. The focus shifts entirely to the organ's intrinsic quality, the fat, the enzyme levels, the DCD factors.
And how risk itself is measured feels different too.
Yeah. Kidney surgeons have the KDPI score. It's imperfect, but it's a single, quantifiable number that helps anchor the risk assessment, allows for clear center protocols.
While liver surgeons rely more on intuition, experience.
Or on a holistic, somewhat subjective synthesis. Pattern recognition built over years. Weighing the fat percentage against the warm time, against the donor stability, against the recipient's MELD. There's no single score that captures it all. It requires deep clinical judgment.
And maybe the most fundamental difference, the consequence of saying no.
That's the bottom line. Declining a kidney offer usually means the patient continues on dialysis, maybe disappointed, but generally safe, waiting for the next chance.
But declining a liver.
Declining a liver, especially for a high MELD patient, could mean they die before the next offer arrives. That stark reality forces liver teams to accept risks that kidney teams might reasonably avoid. The goal shifts from maximizing the organ's lifespan to maximizing the patient's immediate survival.
That trade-off right there, that's the heart of that 2 a.m. decision.
It absolutely is.
It's just incredible to think about the sheer volume of data they process, from blood pressure trends hours ago to a single slide under a microscope to flight paths to policy rules, and synthesize it all in minutes.
It really is a testament to the systems, the technology, and the expertise involved. Every data point, KDPI, steatosis percentage, CIT, CPRA, crossmatch result, gets weighed against the patient's need, the ethical guidelines, and the profound responsibility of honoring the gift of donation.
So here's the final thought, the really interesting question going forward. We see technology like machine perfusion, maybe AI analysis, getting better and better at assessing, even improving these marginal organs. The line between unusable and usable with risk is blurring. So the provocative question is, as tech makes more marginal organs potentially viable, how much risk should we allow or even encourage a desperately ill patient to take? Should policy push surgeons to maximize utilization above all else, getting more organs transplanted even if long-term outcomes dip slightly? Or should the focus remain on giving each individual patient the absolute best chance at a long-lasting graft, even if it means fewer transplants overall? What decision would you make at 2 a.m., holding that phone, knowing your patient's life hangs on whether you accept an organ that's far from perfect, but might be their only chance?